Hi, it's Dr. Emily Cooper. Are you a healthcare professional who wants to expand your clinical expertise and your approach to treating obesity? Beginning November 7th, I'm offering a 3-part, 20-credit live virtual course through the Diabesity Institute. This course will focus on science-based insights into diagnosing and treating metabolic disorders. I've treated thousands of patients over the past 25 years. Our clinics recorded their outcomes in a comprehensive database, and I've learned a lot that I'd love to share with you. If you're looking for clarity, a greater diagnostic understanding, and effective treatment strategies, for more information and for the official credit statement, visit fatsciencepodcast.com and click on the provider course link at the top of the homepage. All right, now to the show.
Welcome to Fat Science. I'm Mark Wright, along with Andrea Taylor and Dr. Emily Cooper. It's great to see you two.
Hey there.
Hello.
Nice to be here. Hi.
All right, another edition of Mailbag. We have listeners from all over the world in more than 100 countries, and they're smart, they're curious, and they all care about their metabolic health. So let's dive right into the mailbag, Dr. Cooper. Lots of people have questions. Our first one is from Anne in Bristol, United Kingdom.
Yay.
I listen to your podcast every week. I'm really enjoying it, learning a lot. I get that diets/calorie restriction doesn't work, and I've been much happier since concentrating on a healthy diet without thinking about calories, although I haven't lost any weight or increased my weight. However, my limited understanding of GLP-1s is that they work by restricting calories. When patients stop taking GLP-1 medications, is it likely that the weight will come back? If this is the case, and if not, how do GLP-1 drugs work to correct the metabolic system? That's from Anne, again, in United Kingdom. This is such a good question, Dr. Cooper, because I think a lot of people have a fundamental misunderstanding of how GLP-1s work, right?
Well, and I don't know if I call it a misunderstanding because, when you think about it, they haven't done good research on how GLP-1s actually work, honestly. So people have the impression that they work by just reducing your food intake, and then that reduction in your calories is what's contributing to this weight loss. But when you think about that, how would that really make sense? Because you've got, I at least have patients coming into my clinic who are almost starving themselves, and they're gaining weight. They're certainly not losing weight. They may be maintaining or gaining weight, even though they've cut out all these food groups. They're fasting for long periods. They're certainly not eating a lot of food at all. And so I started thinking about this many, many years ago. And that's when I started to realize that these medications work in more ways than we're thinking. It's much more complex than the simple calorie in, calorie out equation. Unfortunately, the research hasn't really been done to where, in animal studies, there's a little better research on this, but in human studies, there's very limited, where a person was put on the GLP-1 and forced to stay on a certain calorie level. And then over a long period of time, seeing what's happening metabolically. Unfortunately, those studies have to be done in a really controlled environment, and they really haven't been done, which is kind of crazy. So usually it would be something like the person is just ad lib eating, where they're eating less or they're told to eat less. So once you introduce that, you may not see over a short period of time the actual changes in the metabolic rate that would prove that there's a lot more to this. So unfortunately, the quality of research hasn't been there. So I can empathize with people or sympathize or understand why people, object to when I say this. But when I look at my clinical data, and clinical data is important because especially when we don't have areas of research. So I'm looking at multi-year clinical data. So we've got hundreds of patients that have been followed for more than 5 years in our practice. And any patient that you meet of ours will tell you all we do is tell them to eat more constantly.
It's true.
And
It's true.
we have,
It's
yep, and
true.
we have them log their, pre-appointment, tell us how they're eating, what they're eating. We kind of tell them, remind them, you've got to eat more, or you've got to eat constantly. And they work towards
More
that.
and more often.
Yeah, and our patients are great about it. I mean, they do what we ask, because they do follow the recommendations. And then we measure things in the blood also that are telling us about their nutritional status, but also about their hormonal status. And so, based on all of that, what really, when you think about it, and this is also, these little small pieces of the puzzle are proven in research, the small pieces. It's just that they haven't been pulled together, for a different understanding of this. But the small pieces have proved that GLP-1 is a hormone that our body makes that's a very reassuring hormone. It's called an anorexogen, which is a hormone type that promotes fuel utilization by the body. Let the body use fuel. And so that means it facilitates burning of body fat that's being stored abnormally. Now, that GLP-1 is a hormone that helps that. And so it's not doing it by making you eat less. It's doing that by altering some of your other hormonal chemistry that blocks those functions. And so when you go on a diet, you're increasing the opposite signals that are the orexogens that say store the fuel, conserve the energy. So once you bring the GLP-1 in, you're tipping the balance to where your body's saying, oh, don't store, don't conserve. Let's utilize this fuel. So, and there's a lot of biochemical things that I could explain that do that, that explain that. But, and those little things have been proven in science that of what GLP does to the orexogens and the anorexogens, so that we know that it does do that, and that ultimately in the long run, it will facilitate utilization of that extra body fat instead of conservation. So if you think of it that way, I think it makes more sense. But, it's great that you're feeling free about your eating and you're eating everything and nourishing your body and you feel your weight is stable. You might want to, talk to your doctor if possible about what could be going on, how your insulin level's looking. Because the other thing I found in my many years of treating things is even with the newer medications that have come out, it's not that common that one medicine is going to correct, entirely metabolic dysfunction. So looking for other targets and looking for other things that might be going on is a good idea.
Wow. That is such a great question from Anne. So I guess the short answer, Dr. Cooper, it's less about the calories than it is about brain security, right?
Yeah,
When it comes
really
to these
is.
GLP-1s. Wow.
It really is.
All right. Andrea, who's next?
I have a question from Suzanne. Hi, Dr. Cooper. Your podcast and book have truly changed how I understand my struggles with weight, hunger, and metabolism. Growing up, I was always dieting and restricting, chasing lower numbers, but each diet led to more frustration after pregnancies and even medical programs. Even with years of thyroid issues and variations in my A1C, doctors kept telling me to just diet and exercise without results. Since starting Zepbound, I'm seeing slow progress, and my labs have improved, but finding a good endocrinologist who takes my thyroid and metabolic concerns seriously has been tough. I'd love to know more about leptin and what my levels mean, as I'm still left managing everything myself. Thank you for shedding light on what's actually happening and helping listeners feel less alone.
Aw.
The leptin question.
Well, I feel bad, that someone feels they have to manage things themselves and doesn't have
Well,
like a partnership with someone in healthcare that can just help
it's hard.
navigate it. Yeah. But and leptin is an important player in our metabolism. But as we've described before, it's a little difficult to figure out what's going on with the leptin because there's, first of all, there's the leptin level in your bloodstream. Then there's the way the leptin signals. And so we want to know what the quality of the leptin signaling is as well. So just having a normal leptin level is one thing, but then you have to look deeper to see how well it's signaling. And if there's signaling issues, it does make the thyroid situation look confusing to a lot of doctors. That can be caused by leptin signaling issue, which is often referred to as like leptin resistance. So leptin, we don't want it to be too low. But if it's normal, it doesn't mean it's great unless it's showing that it's signaling correctly. And we look at
And
other
what's too
hormones.
low?
Well, it depends on, that's a good question. It depends on where your body weight is. So if you have a high body weight, leptin is a hormone produced by your body fat cells. So if your body weight's high, your leptin should be high. So if your body weight's high and your leptin's low, that's not good because that means that your body fat is hiding the hormone leptin from the rest of your body. So your brain might not know that you're carrying that extra weight because it relies on that signal to know what your body fat stores are. So what would cause the leptin to be low? Of course we know. Past diets, and when we say diets, we're not trying to say like just focusing on healthy eating. We're saying, restricting calories, food groups, fasting, all of that, underfueled exercise. When you do that, the body fat is more reluctant to really excrete this leptin to announce and broadcast to the rest of your body that you have this extra body fat. So you could see patients who have very high body weight but very low leptin levels. And so that's a discrepancy. So you want to see, is your leptin at an appropriate level for your weight? And it's hard to determine. There are some equations that we use, and people have wanted those equations, which I'm not sure. I'm going to find out. I've been using them for a while, and they were validated for only the higher BMI population. So they're not applicable to normal weight people. So if I can find out a good, where they came from and how they were validated, I would pass them on. But in the meantime, the lab report will show like in X BMI, here's the range, and they'll go through like this huge range. But I would focus on if your weight's high, you should be a high leptin. If your weight's not elevated, it shouldn't be high. And if it is, the signaling issues can be detected by assessing other hormones. So as you can see, this is like a medical thing. It's not for patients to be trying to figure this out. So it's very frustrating, I'm sure. But, I would just say it's not, the other thing is once you get the leptin, what's it going to do? How's it going to help you? Because there's no medicine for leptin. To improve your leptin, it's just sleeping well, eating regularly, eating all the food groups, fueling your exercise. All of those things help balance your leptin.
So there's no drug, Dr. Cooper, that you can take to change leptin levels. That's more of like a barometer of what else is going on?
Exactly. That's exactly right. Same thing with ghrelin. Ghrelin is another hormone that is nice to know, but there's no drug that will change your ghrelin.
Interesting. Mm-hmm. Our next question is from a listener who signs her email Hopeful Mom. I love hearing this podcast address obesity as more than just willpower. I've struggled with obesity since childhood, tried every diet, even had gastric bypass, but I always regain weight. I'm starting Zepbound at a 48 BMI, hoping to lose weight before pregnancy. My A1C and blood pressure are good, and I have PCOS but no other illnesses. 2 questions. Should I be using the lowest effective dose or aiming for the highest tolerated dose more quickly, especially with a high BMI? Also, is it true these meds work less well if you stop and start? How should women planning pregnancy think about staying healthy before and after? Thanks for your insight. So, Dr. Cooper, you've treated so many women who want to get pregnant. Their weight is an issue. It's messed up their hormone levels and stuff. What does Hopeful Mom need to know about GLP-1s, Zepbound specifically, as they're trying to get to that motherhood stage?
Yeah, this is a great question. And it's true. Like, you have to think of, it's not technically the weight that's messing up the fertility, it's the metabolic dysfunction that's causing weight as a symptom and infertility as a symptom, PCOS as a symptom, but the thing about it is, I don't know how old our hopeful mom is, but there is that concern, about the maternal risks as you get older, advanced maternal age, which is as young as 35. So even though it's still very young, there's still increased incidence of complications. And so if a person is not anywhere near an advanced maternal age, then you have more time to work on the metabolism before you conceive. And so that's something to think about too. But if you're kind of approaching that advanced maternal age and you have, starting with that BMI that high, you're going to have to do what you can to get yourself in as healthy as you can, conceive, go through your pregnancy, do some nursing if your health is good, and then you'll have to resume your treatment for your metabolic dysfunction afterwards, because these medicines are not recommended during pregnancy. So that's one thing to think about. Zepbound, what's interesting on the package insert, it doesn't say you have to stop it before conception, which is good. During pregnancy, yes. The other thing is Zepbound just got a new FDA indication, literally, like just recently, or not FDA indication, but an FDA statement. They did the studies that proved that it does not enter the breast milk for nursing moms. And so that's actually great to know. It's still not, they didn't say it's safe, but they said that it's not detected. Or if it was detected in the amount was so tiny that it's just really not significant. So they got approval from FDA to put that on the labeling too. So that's something that might in the future enable moms to get back on their treatment earlier, if that's true. But I think that the main thing is with these meds, it's not about racing to the highest dose. I mean, that would be a big mistake. What you want to do is just start the medication and go to the dose that starts becoming effective. And then once that dose is effective, monitor and allow it to do its thing at that effective dose. There will be a time where it stops being effective, not because you're acclimating to the medicine, but the medicine is basically adjusting in a way that weight set point. So, a certain dose of a certain medication may be able to break through the barriers to normal metabolism by X amount. And that X amount represents X amount of change in that set point receptor. So it's just like you just find out where that is, that dose can do. And then once things have stabilized, and not for like 2 weeks or 3 weeks, but, at least a month where nothing's happening, then it would be appropriate to step it up. That's really the best way, I think, for these treatment strategies that I have found anyway in my own practice. I'm sure other doctors don't agree, but I've had great luck doing that with our patients. It also minimizes the chance of side effects and having to stop altogether and start over, which is really devastating. But you're right that once you're having to, pregnancy is not something that, was a timed, medically indicated time to stop your treatment for your own health. It was just abrupt because you're pregnant. So in that case, the medication being out of your system isn't going to be able to help you that much during pregnancy, and it is unpredictable what would happen. There's definitely a large percent of people who have very good pregnancies because their metabolism was better going into the pregnancy, and there are metabolic hormones that kind of help some people depending on what your metabolism problem is. There are metabolic hormones during pregnancy like oxytocin that can help metabolism. So you never know if your metabolism just behaves nicely during pregnancy or if it starts giving you trouble. But if it does, that's what happens. And you just have to monitor your glucose and things like that during pregnancy, treat gestational diabetes if it comes up. And then once you're on the other end of it, you can resume your treatment.
All right, hopeful mom, keep us posted. Our best to you.
Hopefully it works out.
Yeah.
I have another question from Judith in Seattle. She says, I've heard you speak about how important it is not to restrict calories and to make sure to fuel adequately for exercise. How does one know what an appropriate calorie intake is? I've been overeating so much of my life, but I don't have any reference point with my appetite. Reduced by a GLP-1, I can't rely on my body to give me enough information. I guess because like now she doesn't really have the hunger, she can't figure out like what is an appropriate calorie intake because you're not hungry really anymore.
Yeah, it's true. And
Hard.
even studies show that when you exercise, it also can diminish your appetite, which seems the
Oh
opposite of
yeah.
what you would think. But yeah, it's well, that's why we always talk about mechanical eating.
Right. Eat
You
when you're
know,
supposed to eat.
yeah, and you know what? In a case like this, if Judith were my patient, I would right away refer to our dietitian with the goal of ordered eating, which means making sure to hit all your recommended needed foods throughout the day, food groups and caloric needs for the amount of activity and all of that. And a dietitian's great at setting that up. We don't like to give patients calories and stuff like that. But the dietitian's great at giving options. Like here's 3 different great breakfast options. Here's some lunch options, dinner options, snack options,
Snacks.
pre-exercise, post-exercise, and just getting into that consistent pattern. And the dietitians are great too at working through like any side effects from the GLP-1 that's inhibiting your eating. Because that's the other thing. People assume if you're on GLP-1s, you're not going to be able to eat enough. That's just not true. Our patients do it. And a lot of them, if they do struggle, they definitely work with our dietitian to figure out ways to get more concentrated calories. Maybe you wouldn't be consuming like super high fiber because it can fill up your stomach too quickly. Not gulping water during your meals because that fills up your stomach. So there's little tricks and stuff. But I recommend get an appointment with a dietitian. I always like the dietitians that have experience with eating disorders, not so much the binge eating disorder, but the actual anorexia disorders. Just because with that kind of treatment, mechanical eating is very common. And so they're very familiar with it, with just, you just have to tell them, I don't want to restrict my calories at all. I want to make sure I'm eating enough and I'm doing this exercise. I'm not trying to lower my calories to lose weight. I'm just trying to fuel my body. And hopefully if they have that perspective of a dietitian who's worked with the anorexia nervosa patients, they'll be really good at helping you with like a mechanical eating type plan. And we're lucky in Seattle. Actually, I see that you're from Seattle, Judith. We have great dietitians here. We have a
I
lot of
think it's
really good
also
dietitians.
sometimes like the types of foods that you eat and like what you love, like getting those in and at regular intervals, you can make it happen.
Yeah, it has to be palatable.
Yeah. And I think, for those of you listening who maybe are just about to go on to a GLP-1, you really should know that your appetite is not going to be like it has in the past. There are many
No.
mornings that I get up and I don't feel at all like eating. And it just kind of makes me feel almost nauseous, like the thought of eating. But I force myself to have a bowl of cereal or something that just to get peanut butter toast, something to get into the system. And then throughout the day, it gets easier. But you should know your appetite, if you trust your appetite when you're on GLP-1s, you really could set yourself up for failure. And this
Yeah.
ordered eating that Dr. Cooper talks so much about is really a great way to make your brain feel secure.
It really does work. I could tell you one little quick trick that Jennifer taught me is I have a fantastic protein drink that she taught me about. I put that in my coffee.
Sneak
And
it in there.
it makes me feel like I have a fancy latte.
That's
I love
great.
it. I love it. All right, I think we have time for one more, maybe 2 more. Let's
All right.
see how we do. This is from Alice in Binghamton, New York. I'm 61 years old. Started Zepbound at 250 pounds. I'm currently on a 5 milligram dose. I've lost 28 pounds in the first 44 days of taking this drug. I'm doing the
Amazing.
same swimming and karate classes that I was doing long before Zepbound. I've added weight training since I'm worried about loose skin and muscle loss. Everything's easier. I have great energy, but I worry that I'm losing the weight too fast. I only started listening to the podcast in the past month, so maybe you've answered this already. I'm a little confused about whether or not I should be worried. My doc gave me the prescription, then told me to come back in 8 to 10 weeks for a weigh-in. But at this rate, I might disappear completely before I get to see her. She says, haha. I average 1,500 calories a day of food intake and about 600 calories a day of exercise. I feel great, but she's really worried, Dr. Cooper.
Yeah.
Am I setting myself up for failure? Any thoughts? Alice, thank you for a great question.
That is a
Hi,
lot of weight
Alice.
loss, quick.
Yeah. Thanks, Alex. Well, I'm going to have Mark do a little calculation. Get out your calculator, Mark.
Okay.
But the 1,500 calories is a little bit of a red flag with that much exercise. So, I mean, I don't think that's enough food, so we've got to figure out how you're going to get more food in. So, again, a dietitian would be great to help you if you're not sure how to do it. But to fuel, usually, the little fitness trackers aren't necessarily accurate for your calorie burning in the first place, but it sounds like you're doing a lot of exercise, and that caloric amount, you might squeak by if you weren't doing any exercise, but you need to boost that up. So, Mark, you've got your calculator?
Yep.
Okay, so first thing we want to do is figure out the percent of weight that she has lost so far.
She's
Okay.
lost
So-
at least 11% of her body weight.
Yeah, so it's 28 divided by the 250.
Yep. 11%.
11%. Okay, so now that we have the 11%, now we divide that by the 44 days.
It's 0.003.
Okay, and then multiply that by, that's how much weight per day, basically.
Okay, so
then
times
multiply that by 365. Yep.
Okay, that's 0.92, 0.93.
93%. Is that right?
Yeah.
In annual rate?
Yeah.
So, yeah,
Wow.
so that's too much.
Yeah. Wow.
Yeah,
So
so-
what would be what's an appropriate annual weight loss when you're on these GLP-1s?
Well,
they
what's
say
good-
it's between 10 and 18% or something. What do they say?
Yeah. I mean, as a physician, you look at it. 10% is great, but we always aim for more. But if it could be like above 13%, it's great. I mean, but it's not unusual to have 20% or 25%. But there seems to be something going on here where that is very, very rapid, unless we did the calculations wrong.
No, I think that's right. I mean, 44
No, that
days, 28
calculation
pounds.
is
That's
right.
that's a lot.
But that's in
So-
44 days.
Yeah. So, Dr. Cooper, should she? I'm hearing you say she really needs to eat more.
Well, I think that with that kind of a rate, it does give concern that you could be losing a lot of muscle. It gives that concern, and so what I recommend doing is lowering the dose. Actually, so even though it's at 5 milligrams, talking to the doctor about going to the 2.5, so that you could, in case it's inhibiting the appetite, and then boosting the calories and doing body composition testing, with either like a DEXA scan type body comp testing or some kind of reliable body comp testing that will give you that lean mass amount. So yeah, and she's right to be a little bit concerned about that rapid rate.
Yeah. Okay. So dose adjustment and how much she's eating. That's a great question. All right, Andrea, I think we have time for one more question.
Our last question is from Anonymous. We don't know who sent it in. Where are we with insurance companies covering Mounjaro for pre-diabetes? I had coverage previously, but when I changed insurance companies, the new company denied coverage. Boo. With a history of my mother and grandfather dying of type 2 diabetes complications, it's critical that I continue managing my insulin, glucose, and weight in maintenance. This is a really major thing because so many people are having this issue, and I mean, I'm very lucky at this moment because God knows what's going to happen right now because I have Medicare. But I mean, what's going on? Like,
Yeah.
I know that there are some options, but some of them are expensive. But there are a few different ways to go, and you do have some. I don't know if we should call them sneaky, but like some ways that we can, like ways of workarounds. Let's call them workarounds.
Well, I have a question though, because this person says that they started on Manjaro, but it sounded like there was originally maybe an elevated weight at first, not just prediabetes, because they're talking about maintenance, but I don't know if that's maintenance
Yeah.
about the glucose or what. But if there was initially a high weight, I would definitely try to get coverage for the Zepbound form of the
Oh
tirzepatide.
yeah.
Yeah, because the coverage is possible if you can demonstrate that there was a high weight, even if you're not at a high weight now. So that would be number one idea, is to try to put it through as Zepbound and do a prior authorization for that based on the initial elevated weight with comorbidities of the prediabetes, because that meets the FDA indication, even though it is the identical same medication. So it's
So
kind of
crazy.
it's just also silly because it's the same exact medicine, just a different name and different color pen. But if there may not be coverage for weight-related treatment, and that may be why the physician tried going the other angle, with the Mounjaro, even though there was no diabetes, which is usually required for Mounjaro coverage. So, getting it covered for prediabetes is really, really tough. I mean, it's usually only by mistake that the insurance companies approve it,
Right.
usually for that. But you could just pile on all the comorbidities, the family history, and try to do an appeal, try to be a squeaky wheel and see if you can just make them just want you to go away because you're just annoying them. Um,
What was that sleep apnea thing? Was
yeah,
that a
sleep
thing?
apnea. Yes, sleep apnea, especially it's with Zepbound. Again, the Zepbound form, s- it's it's sleep apnea and elevated weight. So you got to
Oh,
have, yeah. And so
I
um,
remember that was a
yeah, it's an angle to take, but it's only if you have coverage
hard.
for for the weight related treatment.
Right. That was
So, and if
hard though.
that's not possible, and if your maintenance dose is kind of low, you could look into Lilly Direct Pharmacy for Zepbound. They won't approve it for Mounjaro to get the low price because if you don't have diabetes. But if you ever had an elevated weight, they will approve it as Zepbound through Lilly Direct Pharmacy, which is a cash pay option that's less expensive. It comes in vials, brand name vials. And if that's not an option, because it's still too expensive, then Canadian pharmacies have the Zepbound in a pen and the Mounjaro pen in a pen that's clickable. And so you could ask your doctor to order a higher strength, and that way it will last a lot longer. And you'd have to just make sure your doctor gives you the right advice for how many clicks are the dose that you need for that pen. So those are just my thoughts. I don't think we're going to see improvements insurance wise. I'm a little bit concerned that we're going to see the opposite happening soon.
Right.
So I wish I had better news.
Yeah. Okay. Well, all good stuff. Thanks
Sorry.
so much to everyone who sent in a question. And it's been fun spending some time with you once again on another edition of Fat Science.
No diets, no agendas, just science that makes you feel better.